In the abscess formed in this specimen, there is overlying skin erythema and a central area of thin and necrotic skin tissue. The area is gently palpated to find the maximum point of fluctuation. The first step is to make a generous incision at this point. This will result in an immediate release of pus, which should be cleared away using swabs. We are left with a cavity which still contains pus and an overlying linear skin incision. It is vital to ensure that the skin incision cannot close over. This can be achieved firstly by making a generous skin incision. Alternatively, an elliptical incision could be formed or, as in this demonstration, a cruciate incision made. At this point, a swab is taken, placed in a container and sent for culture and sensitivity tests at the microbiology lab. The next stage is to express the remaining pus using two-handed pressure and plentiful swabs to clear away the exudate. We are now left with a cavity and an overlying cruciate incision. It is sometimes necessary to excise the edges of necrotic skin tissue, as shown here. A finger is then inserted into the cavity to break down any loculi, leaving one continuous space. If necessary, the cavity can be irrigated with saline, using either a bladder-tipped or standard syringe. On occasions, 3% hydrogen peroxide can be used to help clean out the cavity. A pack must then be inserted into the cavity to keep the ostium open and to absorb any further exudate. Either a saline wick or an alginate dressing can be used. The pack is loosely inserted and the wick trimmed, leaving a small tail to aid subsequent removal. The wick will remain in place for about 24 hours and will then be replaced by an alginate dressing.